Thank you very much for your question. I think it's true we are in a new era where we have the development of the Blinatumomab, that is a CD19, CD3 bispecific T-cell engager. And I think the best model is a Phi plus ALL. There are two main studies, the study from the Italian group, the ALBA study, when they test the association of dasatinib plus Blinatumomab, and they find excellent progression-free survival or leukemia-free survival, with a follow-up a little more around 34 months. They find 4 patients who had a CNS relapse and also different type of relapse with a new mutation, T315A mutation. The question is maybe dasatinib is not sufficient and PONA is maybe better. The other question is we need maybe chemotherapy to avoid CNS relapse. The second study is about ponatinib and the association with blinatumomab and was published by Jabour and colleague. Even in patients with de novo Phi plus ALL, they performed the association of ponatinib at the beginning 30 milligrams per day, and when they obtained the molecular CR, they decreased to 15 milligrams per day. What they see is the excellent also PFS and overall survival. Only one patient underwent allogeneic stem cell transplantation, but they also observed some CNS relapse. It's why we had a recent study when they combine a little bit of chemotherapy plus PONA plus blinatumomab, and we're waiting for long-term follow-up, but maybe this is the best combination, not to totally forgive to chemotherapy, but to reintroduce it to avoid CNS relapse. The quite new data is to use blinatumomab in first line now, because it has been shown in the New England that even if patients are MRD negative, they benefit to receive blinatumomab to have a better PFS and OS. And in fact, in the French GRAL, that is a cooperative group, we will incorporate blina in the first line. I think there are also interesting data about CD38 antibody, but more in TLL. And we use sometimes CD38 antibody in TLL relapse. We will look at in first line in the next months or next years. And in relapse also, I think it's interesting to look at venetoclax and azacitidine, even in ALL, because there are some reports that show very interesting data, and sometimes we don't know what to do with this patient. So I think there are different kind of treatments that will be developed, and we are performing them nowadays when patients are in relapse, but we have to better understand the mechanism to see if we can use them in first line. Yeah, it's a difficult question because it's good because we have seen that the prognostic of ALL patients really changed the last 5 or 8 years, but there are still patients who relapse. So first, the main goal is to cure patients in first line. So it's why maybe for B-ALL to use, I think maybe chemotherapy, antibody, and could be sufficient. And when people are at high risk of relapse, if they are KMT2A rearrangement or if they have IKZF1 mutation plus another mutation, to undergo in first line to CAR T cells or allogeneic stem cell transplantation. So we don't have the response now. And for Phi plus ALL, it's really fantastic to see the prognostic of this patient now. And we think really have to use TKI, maybe the third generation of TKI, and to use also blinatumomab. This morning that a group is using dasatinib plus CD19 and a CD22 CAR T cells. The results were very impressive, but I don't know if in clinical practice we will be really able to have access to this kind of treatment. And maybe a PONA or another one, plus antibody, plus a little bit of chemotherapy could be not so much toxic and to be very effective.